Welcome to Leveraging the Laboratory, a Mayo Clinic Laboratories podcast for administrators, outreach managers, and laboratory professionals to learn how to best leverage and optimize the laboratory for patients, clients, and staff. I'm your host, Jane Hermansen, Outreach Manager at Mayo Clinic Laboratories. Joining me today, my favorite guests, Dijkman, Dulkes, and Wendy, Daigle, who are Outreach Solution Strategists within Mayo Clinic Laboratories. And as you know, we work with hospital laboratories across the country. And one thing we see a lot when we work with lab outreach programs is that they're really good at doing the testing, but they may not have as much confidence around the business processes. And when it comes to managing the business of the outreach program, the bottom line is literally the bottom line. You want to get paid for everything you can, and you don't want to leave any money on the table. So please realize, here's the disclaimer, we are not lawyers and this is not intended to be legal advice. So if or as you implement any new policies, please make sure to engage your own legal counsel and make sure that you are compliant within your own organization and state regulations. So when we look at laboratory outreach programs, we see some really unique or out of the ordinary services that a program might perform, where the outreach program is going above and beyond. And these actually may be things that you can actually charge for. So things that we think about, something basic like paying for travel or mileage. And outreach programs drive around a lot, many miles per day, hundreds of miles per day. And when you think about how many miles are involved, it's a lot of cost attached to that. So Wendy, let's start with you. And we think about courier services. What are your thoughts related to maybe charging for courier service? What's standard? What's expected? What shouldn't you charge for? What is extra mile, literally extra mile? And should you charge for going that extra mile sometimes?
Sure. Hi, Jane. I certainly can share a lot from my own experience with this, doing lab outreach. The courier services were always included in the cost of doing the business. However, when our expectations weren't aligned with the clients, we incurred a lot of unnecessary costs for pickups that we weren't anticipating. In our minds, we didn't think it was a 24/7, one size fits all service offering, but we hadn't maybe fully defined the scope to the client, or, maybe we did at one point, but over time people had moved on and the lines became kind of blurred or faded. And at the same time, we weren't consistently monitoring the on-demand pickup activity, those stops that weren't part of the scheduled route. So, kind of without defining who gets what and when, customers would call whenever they needed a stat pickup, which, is really difficult then to manage resources and costs. The lab staff would complain that they had just sent a courier to a SNF's first floor and now their second floor is calling for one. Or, we dispatched a stat to our third party kind of vendor when we had employed couriers still in the area that could have got it. Holidays, those were always a challenge too. We had a skeleton crew and we really used their third-party vendors for couriers. And I remember one time we got seeing a charge for $100 to get a urine from a nursing home that was a half a mile away from our lab because it was a holiday premium cost. So when those courier invoices come in, it was painful to see that there were quite a few charges that could have been avoided. So we needed to become efficient with managing our internal resources and really defining the service scope with our clients. So some of the changes that we made that made a big difference in terms of helping to manage costs and better utilize internal resources first for couriers, because we did happen to have employed couriers, and then during regular operating hours, and then we would use a third party for after hours. So one of the things that we discovered is assisted living facilities. We were doing after hours stat pickups on the weekends when really These were ambulatory patients, and it really should have been a courtesy, routine service that we were providing. So, we met with our assisted living clients, showed them the data, and said, we want to continue to provide service for you, but it's going to be, Monday through Friday, 9 to 5. All your physicians have hours. And that it wouldn't be available, stats would not be available, and it wouldn't be available on the weekends. So that was one area. And then we looked at building in additional, we kind of call them scheduled on-call stops for our nursing homes. We would have scheduled stops, maybe one in the day, one in the morning, one in the evening for the nursing homes, but if they had a stat in between, we had a lot of couriers, a lot of different routes. They were kind of crisscrossing in the area. So in looking at a couple months worth of data to see when, who was calling and when for these on-demand pickups, we said, hey, we've got resources. We could build in a time. Call us if you need the pickup. We'll come at that time. If you don't need the pickup, we won't send a driver. But that way we could leverage our route couriers. We still got the specimen back to the lab at the end of the route. The courier really didn't go out of their way, and it fell within the same stat turnaround time that we had established as a standard. And so that significantly reduced our stat costs. And then, we had met with our skilled nursing facilities and our hospital clients who do have 24/7 needs, but our operations for courier service wasn't 24/7. So when our regular service ended, we did use a third-party vendor, courier vendor, for after hours, and that was a cost that the lab was paying for. And in looking at the data, because we had no guidelines in place for the clients, they just called whenever. We'd go at 2 in the morning, 3 in the morning, and we couldn't determine what was the stat, what wasn't. So looking at the average amount of stats that were called after hours among all our homes, we determined a reasonable amount that we would provide after hours at no cost each month up to for the clients. And then if they wanted more after that, they would incur a fee. One lab, we charged back the full, our cost, that what the third-party vendor had charged us, we would charge that back to the client. Another lab, we charged back a portion of that. And then the other thing that I did to help kind of manage that, help the clients manage that activity, and they had some skin in the game now, is I asked our courier vendor to start sending me a weekly invoice of the activity rather than a monthly. So I could manage it as we went. And then as the client started to exceed their limit, I could shoot the administrator and the director of nursing a heads up email. And then they would have that information, and they wouldn't be surprised, they could follow up with their staff, let them know, and they wouldn't be surprised when they got the invoice. Mm-hmm. And then the last piece was the communication piece, letting our staff that answered the calls and did the dispatch, giving them tools of, who to best give this to kind of, manage our costs. I created posters for our clients that showed their schedule times, and then talked about the, after hour service is available, but there could be a charge for that. So they could clearly post that in their area so staff would know. And then we also put that as part of our contract agreements, our lab service agreements. Courier services were available, something along the lines of available at no cost for the mutually agreed upon times. If after hour services are needed, potential costs could be incurred. So we left it a little vague because schedules, times, everything like that changes. So we didn't want to be specific, but we did state that there could be potential costs incurred for after hour services.
So I'm just curious, did you find a decrease in calls for stat when they had a little skin in the game?
Absolutely. Absolutely. It was really eye-opening, Jane, to both us and to the client. And then we also discovered things like, oh my gosh, we looked at why they were, like what type of tests. When we originally did the current state assessment, and looked at the data for a couple of months. We also looked at what type of tests they were calling for stats. And one of them we discovered it was for urine cultures, because the culture was only good for, I forget, it was like a couple of hours after collection. It had to get to the lab for testing. So they were calling stats for that, even though we didn't run the test stat. Well, the lab has the preservative tubes for urine cultures, and it could be good for up to 72 hours if it was put into that tube unrefrigerated. And so once, we were able to, provide those supplies that we readily had on hand. We just hadn't told our clients that they were available, and the clients loved them. And so that helped reduce a lot of costs too. But I mean, yeah, I would say we saw easily about a 20 to 25% decrease in volume and costs once we really looked at the activity, the on-demand activity, reestablished the scope with the clients, and then had the clients have some skin in the game for additional services that we didn't take away. It just became a premium service. We had added in extra pickups for them when we could, where it made sense and there was no cost to them, and it could be on demand. But if they wanted the extra pickups, again, we would provide them, but they would be paying for a part of that, if not all of that cost for that kind of premium service.
Sure. So I think you really kind of tied problem solving, root cause analysis, all of that with a financial story, and then moved it into a nice place where you weren't actually on the hook for really expensive services. Ellen, I know you have some different and some similar experiences. What are your thoughts about perhaps just different ways that you might be able to charge or consider charging for maybe some really expensive courier costs?
Well, it's just, I think stat, everybody interprets what stat is, a four-letter S word. I had a doctor that was an hour and a half away, and she wanted her test done stat. And when I started to see all these expensive tests for a stat courier an hour and a half away, I called the practice manager and I said, why does this doctor need this test? Well, I don't know. She wants it to the lab as soon as possible. I said, well, it's not going to get run until tomorrow morning. It was a expensive anatomic pathology test. I said, it's going to arrive tonight. I have a courier coming at 5 p.m. And then there was some pushback from the office. I said, well, do you realize what this is going to cost? And I have a routine courier. And once we had some dialogue on it, and I, confirmed with the courier, and the courier went over there and explained, when the pickup was, they were like, oh my gosh, this can totally be done routine. And then they started their ordering practices, and that made all the difference in the world. So really having a gatekeeper to really watch who's ordering stat makes all the difference in the world. And similarly with nursing homes, we go over the agreement and say, Monday through Friday, these are your courier pickups. And if you want it stat outside, maybe you pay $25 and you set up a separate agreement. Or they may have a medical assistant that runs that lab over to the lab if they truly want it stat. So setting up those lines of communication. And then overall as an organization, I liked what Wendy said about having multiple courier pickups. There are many parts of the organization that move, I don't want to say widgets because that's not what they are, but you have pharmacy, supply chain, you have food service, biomedical, laboratory, all moving things within a health system. And how many organizations really look at the whole book of goods to lean processes and move transportation logistics to streamline and get economies of scale to move courier operations? Might be a nice way to save money for the entire organization.
Sure. And when I think about some super rural areas, they're actually transporting specimens by airplane. So they might be booking things by plane. And of course, there's cost there. And truly, in a client bill situation, perhaps you make sure you're building those transportation costs into your overall price per test so that you're not on the hook for all of those. So I think that that's one way. Clearly, going the extra mile doesn't have to cost us an arm and a leg if we actually do it smartly. So I think about other standard services. Courier, certainly a very standard service. How about phlebotomy. So a couple of years ago, thankfully, we realized an increase nationally in phlebotomy reimbursement through CPT codes. And there was an additional bump of $2, I think, for a patient that was in a skilled nursing facility. But in order to recoup that money for the additional cost of going to the skilled nursing facility, you need to code it differently. So you need to code it as a different location, and you can also charge a trip fee when you're traveling to a Medicare patient's location to collect a blood specimen. So there are some ways that you can actually get some extra money for phlebotomy through serving skilled nursing facility patients or remote patients. And what I would encourage, if you want to know more about that, again, not a lawyer, lab scientist, but if you take a look at the Medicare Claims Processing Manual, Chapter 16, it's for clinical lab services. It's a great resource and can tell you more about which codes to use and what the policies and regulations are around that. So sticking with the phlebotomy topic, Ellen, I know that you have an elderly parent who has needed to have blood drawn. What do you think about charging for home phlebotomy for patients that don't meet the Medicare homebound requirements?
Well, I think it would be a priceless service. I can order a pizza, I can order food, I can call up and get it door dashed. But I know that when my mother needs blood to be drawn, I need to leave work, drive an hour and a half to pick her up, put her in the car with her walker, and we have a lovely time. We find parking in a parking garage. I try to find parking. I try to leave her with her walker, and hopefully she doesn't fall down or her walker goes flying down the ramp. And I try to bring her into her blood draw. But it would be wonderful if I could accommodate somebody to come to her house. It's priceless for me. I would pay, I don't know, sometimes I would pay $100, $50 to have somebody come to the house to draw her blood. She's an easy stick. But to have some reliable service come to the house in her remote where she lives, her remote area. It's outside of a big city, but not very far, 15 minutes from a town of 15,000 people. That's, not a big city, but, it would be accommodating for her and for me. And I can imagine people with little kids and all generations could benefit from that.
So truly, if we're willing to pay probably even more, when you think about a DoorDash or Uber Eats or something, we frequently pay more for the delivery fee than the food is actually worth in the first place. So convenience does have certainly its aspects. So I think that's a fantastic idea. And there are some groups out there who are actually doing it, some outreach programs who are doing it very routinely. So maybe we can talk about that on a future one. Wendy, how about some other things related to drawing that maybe there's not a CPT code for that a laboratory is going the extra mile for and drawing? Do you have any other examples that you can think of?
Well, I was just going to add to Ellen's what Ellen was saying about the concierge kind of service for phlebotomy, and I agree. I think there is a market for that for a variety of reasons that Ellen had stated and more. And I think especially in heavily populated areas, and maybe with populations that would be willing to pay for that service. But I think if you would need to have the right management tools in place. Back in the day at one of the labs I was at, we did provide home draws. Now this was for the kind of CMS defined homebound patients. It wasn't concierge phlebotomy, but just with that experience, as the need grew, as our patient base grew, the homemade scheduling tool that we had started with no longer kind of met the growing needs of that the house call service, because you have to think of not only patient volume but cancellations, confirmation calls, rescheduling. All that's a part of it, just like kind of any other appointment service. And this was also before the GPS apps were readily available to kind of map out the most efficient routes. I think at the time, those big clunky, and I had one, Garmin's that you would attach to your dashboard were just coming out. So I don't know if you remember those. They're kind of like chunky like the TVs were before the flat screens came out, but they just kind of showed you how to get from point A to point B. It didn't help us with, hey, we got 50 patients in this zip code. What's the best route to map out so it's the most efficient? So really needing a good automated scheduling, notifications, logistics tool, and thinking about how you'd want to handle the payment, upfront or after the services are rendered, are things to think about. And I'm always a fan of pilots. Start with a small kind of subset. In the Boston area, concierge PCP practices are big. Maybe that it would be an opportunity if you have those in your area, to kind of collaborate with on a pilot there and kind of see how it goes with a small group, identify the operational kinks first, before rolling it out to the masses. But separate from that, some other things that we had kind of thought about with our outreach program for phlebotomy draws were, maybe participating at community health fairs, direct-to-consumer test offerings for maybe a select menu of tests that the patients from the community could come into. They wouldn't need an order from their doctor, pay out of pocket, pay cash for that. Our draw stations, we also saw patients would come in with orders from chiropractors, which we could not draw those patients, unfortunately, but we didn't do that. But there might be other type of draw kits that you could client bill back to providers that just needed the blood drawn, but the testing wasn't going to your laboratory. And then just another thought I had was infection control support for nursing home patients, clients, whether it's charging back for if you're able to produce quarterly reports for them. I know it's always been a challenge, it seems, for the homes to create those themselves. And then we also had a microbiology supervisor who loved our nursing home clients, and she would go out on site to provide consulting for them, and we would charge for her services for that.
Awesome. So Ellen, I know that when in your past you did something really, really interesting where you realized that you couldn't deploy phlebotomists everywhere they needed to be. So why don't you tell our audience about kind of the unique way that you changed the story and helped people do things on their own?
Well, there was no one else to do it, Jane, so I rolled up my sleeves. So I had nursing homes that wanted to use our services, and our laboratory, as you all are, strapped for phlebotomy services and education of phlebotomy service. So there was a conundrum, clients that wanted to use our services and a laboratory that could not provide laboratory services. So what do you do? So you teach them to fish, Jane. So I went to my administrator and presented a solution. I said, I'm a med tech. I know how to draw blood, but I'm not a certified trainer. And I said, what do I do to become a certified trainer? And can they teach me to be a trainer? So they in the phlebotomy area were willing to teach me, or teach me again, train me again, and check me out to be a trainer. So I did. I spent 2 days, 2 weeks on the day shift down in the phlebotomy area, and just basically updating me. I haven't drawn blood, for a long, long time. And, the needles have changed, but, the skills you never forget. It's like riding a bike. So I spent 2 weeks drawing blood. And then I took the resources that they had, the order of draw, and their competency, and I just took those documents and I refined them for training for the nursing homes. And then I put together a competency packet for them, and I order of draw for the nurses or for the MAs at the nursing home. I went over specimen collection and labeling. I took our documents and I put them into the toolbox for the nursing home. The laboratory handbook, trained them on that, supply ordering. So I really was the boots in the ground to really onboard that client, which I was doing anyway. I just added how to draw blood. And then I trained the trainer and I went and spent time with them. And then I did annual refreshers. And I spent, when we onboarded that client, the first week with them, going around with the trainer and making sure how they package the specimens for the courier. And really what was the outcome was that client that could have really been, that 80-20 client that's always your problem, they were a success. And anything that failed, I knew about it and could fix it right on the spot. So it really was a success story in lieu of having an educator that could go there and do that. I did it myself. And it really was a nice model to have someone do that.
Sure. Well, and certainly that would be a service that you could charge them for because you're teaching them a skill that's transportable elsewhere. So I know you didn't charge for it, but
No.
you certainly could have, right?
Correct.
So,
But, the selling point for that was you can draw the patients when they are ready. They're having their breakfast, they're going to respiratory, they're going to PT. The phlebotomist comes in, they're never in their bed. You don't know who they are. You're interrupting their schedule, but by drawing your own blood, they were very open to it. And many of their staff had already known how to draw blood. So it really was an easy transition. But I really recommended that model because it was more patient friendly for their residents.
plus you brushed up on your skills. So,
It's like riding a bike. I loved it. It actually brought me back to my roots.
confession, I have never drawn a patient wearing gloves because the PPE was not required back when I was in a hospital drawing blood. And then I left and took a role where I didn't have to draw blood anymore. And I don't know that I would be as good as you are at it, Ellen. So with that, you know what, guys, when we start talking about stuff that we like, time flies really fast. So truly, I think that it's time to wrap our conversation today. Wendy, Ellen, you guys have both given some really good ideas about really kind of ways that laboratory outreach programs go the extra mile, engage customers, some problem solving, really with the patient in mind to make sure that we're driving to a good outcome. And once in a while, when you're doing something that is extra mile, you may be able to pay for it as well. And again, for the audience, please know that this is not intended to be legal advice. So please always work with your own legal counsel to make sure that you're in full compliance with all the federal laws, all the state laws, and things that are within your own organization's policies. And for our audience, please know that if you have a question for the MCL Outreach team, please feel free to email us at mcloutreach@mayo.edu, because you never know, we might use your question in our next podcast. And speaking of podcasts, if you're looking for another great podcast from Mayo Clinic Laboratories, please check out Answers from the Lab. This is hosted by Dr. Bobby Pritt and features regular updates from Dr. Bill Maurice, who is our president and CEO. This podcast offers quick takes on industry news and deep dives into the innovations and trends that shape clinical diagnostics today. New episodes drop twice a month, and you can find them on our website and on your favorite podcast app. Thank you so much for listening to Leveraging the Laboratory, a podcast from Mayo Clinic Laboratories. If you've enjoyed our podcast, please subscribe. And until next time, we encourage you to continue to promote your community-based hospital laboratory. The needs of the patient come first.